My name is Tufik Assad, and I'm a pulmonologist and ICU physician at Williamson Health. Thank you so much for tuning in to Health Talks from the Inside Out.
Dr. Tufik Assad, thank you so much for joining me on the podcast today.
Thank you so much for having me. I'm really excited about our chat.
Yeah, me too. So you are with our Williamson Health Medical Group, and Let me see if I get this right. You are board certified in internal medicine, pulmonology, and critical care.
That's right.
Okay, and we're going to talk mostly today about critical care, but I first wanted to begin by asking what drew you to medicine, and maybe ultimately to those specialties.
Yeah. So my father was a physician. That was probably the earliest introduction into medicine. So a lot of talk about medicine at the dinner table, and it just was something that I was kind of immersed in at a pretty young age. So that's probably what got me into medicine. And then once you go to medical school and start figuring out what you want to do, there's like all these different subgroups of personalities that happen in medical school. Different types of people tend to go into orthopedic surgery, ER, what have you. And so I was drawn to the internal medicine crowd. That was the first decision. I became an internist. And I do feel like, this will probably come up later in the conversation some. Internal medicine is all about understanding the whole body, the whole person, putting them in a package. So before you even get to their specialty, understand them as a one. And then once I did my internal medicine residency, I was drawn to pulmonary and critical care. So it is a combined fellowship. So I did training in lung disease, pulmonary medicine, and in ICU medicine. That's the critical care part. We sometimes refer to that as being an intensivist. So I'm a pulmonologist and an intensivist. And it's just something that I, at a pretty early phase in my medicine residency, realized these were kind of my people. So we do a lot of intense stuff. We're going to talk a lot about the intense stuff in the ICU. But I also have an outpatient practice. I see people with lung disease. I know you already spoke with Dr. Sherman and Dr. Phillips, who talked a little bit about the outpatient side of what we do. So just having that side of medicine, doing outpatient medicine and working in a hospital setting in the ICU, and also doing bronchoscopies, which is something that Dr. Sherman and I both take a lot of passion in and do frequently. Just having that breadth of exposure is really what has drawn me into this field.
Yeah. I love that. So tell me a little bit about your actual schedule. Since you are doing so many different things throughout the week, throughout the month, what does it look like?
Yeah, so it's a lot. And so it actually is at times a bit chaotic, but I kind of appreciate that chaos. So there's 4 of us that do routine ICU care. And so we rotate 1 week on in the ICU and then 3 weeks out. So there's 4 of us, so every week one of us kind of goes in sequence. In between the ICU weeks, mostly I focus on my clinic. And so I do office work most of those other days, other than scheduled days off. And 1 day a week, I do bronchoscopies. So I really like carving out a lot of time to do that because it's something that, takes a bit of time and effort. And I like to have it only on my day, that day where I can focus on the procedure. And so, it's a lot. And so, and my clinic patients are my clinic patients even when I'm in the ICU. So it's not like I can completely shut off that part of my brain. So if one of my office patients calling with symptoms, complaints, whatever, I have to address those when I'm in the ICU. So I'm always available to some extent, obviously, except when I'm off for my clinic patients. But in general, though, it's kind of segmented like that.
Yeah, so very busy.
Very busy.
So we are going to talk mostly about the ICU, but I know that the bronchoscopies is very important to you. You're very passionate about that. So in case someone didn't listen to Dr. Sherman's podcast, give us a quick little overview about what that is and what a benefit that is to our community.
Absolutely. The quick version is bronchoscopies are a procedure where we use a scope with a camera and a light at the end. We go down people's windpipes and biopsy things inside the lungs, ranging from infections to cancer to anything in between. And so we have a navigational bronchoscopy system here where we have extra technology that helps us go way out into the periphery of the lungs. And so it is something that both him and I have carved a big interest in, and it's something that we both routinely do pretty regularly. And so bronchoscopies are kind of the invasive scope procedure that a pulmonologist does.
Right.
And not every pulmonologist does it because you have to get extra training and time and focus to do it well. And so it's something that him and I both do. And it's a great service that we can offer to our community to have patients with suspected lung cancers or other lung abnormalities get the care they need here in Williamson County.
That's great. Okay, so let's pivot back and talk mainly about the ICU, the intensive care unit, in case people haven't heard that term. And you said you and your partners, you take 1 week on and then 3 weeks off.
Sure.
What does that actually mean? Are we talking 24/7 for that entire week?
Not the whole week, because that would drive even the most patient person crazy.
Right.
Because that's a lot of hours of being available, being in the hospital, being on call. And so I don't have to go into the great detail of it, but that during that week we are on every day that week. So from whatever time we show up till whatever time we leave, we are the people on call that day. The nights are covered by us, but it's not the person who's in the ICU all week covering all 7 nights.
Okay.
You know,
so one of your partners
would cover that night from home, and we are available to come in as needed. And so don't get me wrong, it's still very busy and very grueling and very draining by the end of that week. Right. But yeah, that's how we generally staff it in the ICU.
Okay. And for someone who might not be familiar with the intensive care unit, can you kind of describe what that area of the hospital is, what happens within?
Sure.
What is it?
So the way that people flow through a hospital, if that's the way to word it, is that the vast majority of people come through an emergency room. And so if they have a complaint or they call 911 or they just want to walk into the ER, they come into the ER to be assessed by our emergency room staff. Then a decision is made, do they go home or do they come into the hospital? And they would either be admitted to the hospital ward, the floor is what we call it sometimes, or the step up from that is called the intermediate care unit or the IMCU. That's another name for that is a step down unit.
Okay.
More than the floor, not quite the ICU.
Okay.
And if they are the sickest patients in the hospital, they're going to come into the ICU. And so it's really depending on how sick they are, what their needs are, what their vital signs are looking like, what procedures they might need. Those are all of the factors that go into deciding where a patient goes.
Okay.
But long and short of it, if you're the sickest person in the hospital, where you need all the attention from hospital staff, nurses, therapists, providers, you're going to come to the intensive care unit.
Yeah. So what might be some of those conditions that some of these patients are dealing with?
It runs a very wide gamut. So we see patients, and this is back to what I said earlier, I really have, enjoyed my internal medicine training. And so I take care of the whole person. And so I am a subspecialist in the sense that I do focus on lungs, but when you're in the ICU, I'm taking care of all of your complex medical problems. And many times it's more than one thing at once.
Right.
So I could really run down like from head to toe, like what might be some common conditions that lead to an ICU stay. Yeah. So starting with the head, so a big stroke, bad seizures, a head bleed. Those are some of the neurologic conditions. Cardiac stuff, heart attacks, pulmonary embolism, blood clots in the lungs, heart failure, AFib, lung stuff, pneumonia, respiratory failure, aspiration, bad infections throughout your body that can lead to sepsis, which is an overwhelming infection that affects the whole body. Those are some of the many reasons why people come to the ICU, which is partly what makes the job really fun and exciting, is you have to be kind of knowledgeable on a lot of stuff and things can develop while they're there. So you come for one problem and then another problem develops.
Right. Because somebody might have come in with a heart attack, but they also have diabetes.
Absolutely.
And so, so it's all
a great analogy.
Affecting each other and you're having to...
Yeah, we deal with all sorts of complex stuff.
Okay, so you just mentioned sepsis, and I did want to ask, we recently heard the sad news of the passing of NASCAR driver Kyle Busch, and I don't think we know all the information yet, but what we're hearing that it possibly was pneumonia that turned into sepsis. So talk a little bit more about sepsis and the severity of it and how people should know maybe if they should be concerned about that or not.
Yeah. Obviously, super tragic. He was really young, in his early 40s. Yeah. And it sounds like he went from sick to really sick quite quickly. And, that happens. I want people to know that that's not common. Like, what happened to him is not the normal way that this goes down, especially for somebody presumably as healthy as him. Again, I don't know all the details, and I don't want to presume. But sepsis is the condition where you get an infection somewhere. So it can be from any kind of infection, a urinary tract infection. It can be from pneumonia. It can be from cellulitis, an infection of the skin, meningitis, affection around the brain, sinusitis. Really, name the spot. If there's an infection there and the body's inflammatory response goes a little haywire, that's what sepsis is.
Okay.
And it can really progress to the most severe form of it, which is septic shock. That's where your blood pressure plummets, and we have to do things to support your blood pressure. Oftentimes, you have to be on a ventilator. You have to get a lot of life support.
Yeah.
The fact that, based on what we've heard, he went from, in the ER, I believe, and then home, and then back to the hospital, and then passing away within a day or two after that, means he had a really rapid progression of his illness. But I don't want people to think that every time you get pneumonia, this is like what we expect to happen next. This is the rarest, most severe manifestation.
So you've mentioned a few pieces of equipment or technology, like ventilator, as we've been talking. So can you kind of walk through what are the most common pieces of equipment or technology that you work with in an ICU room?
Sure. I'm a lung doctor first and foremost, so I'll talk about the lung stuff first. So we give patients oxygen through a variety of means. Something called nasal cannula. That's just like oxygen in the nose if you've had a procedure or a surgery.
So that's the tube.
The tube, the thin little tube that goes into your nose. That's the entry level amount of oxygen. And so we measure oxygen flow in terms of liters per minute. And so you can give somebody 2 liters or 3 liters, and depending on the system, up to 10 liters of oxygen that way per minute. If that's not enough, then we have something called high flow oxygen. So as the name implies, it gives it oxygen, but at a higher flow. And so it can go up to 40 or 60 liters per minute. And so that's really blowing oxygen and air into the patient's lungs through the nose. If we feel like they need more support, the next level up is usually called a BiPAP. For patients who have sleep apnea, a CPAP or a BiPAP or routine devices that they sleep with at night to kind of help treat their sleep apnea. But a BiPAP in the hospital setting, in an ICU setting, is meant to support someone's breathing. So not just for sleep. While they're awake, they'll have this mask on. So it's a tight-fitting mask that goes usually over the nose and mouth, connected to a machine that blows air in and under their lungs with oxygen to really help inflate someone's lungs and help their breathing. And then the most severe form of respiratory support is a ventilator. And so to get a ventilator, you have to have a breathing tube inserted through your mouth down into your windpipe. So you have to get put under general anesthesia to have it done, because you can't tolerate somebody putting that down your mouth without gagging, coughing, fighting. So we put someone to sleep. We then connect that tube to a ventilator, which blows air in and out of their lungs. And generally, to tolerate it for however long you're on the ventilator, you're in some degree of a coma. You're not completely out, but you're on medicines to keep you sedated and comfortable to tolerate it. So that's the kind of gamut of respiratory support that we do in an ICU. There's a whole lot of other support. And so we often measure people's blood pressure. And so we have what's called an arterial line. That's a catheter that goes into an artery and measures your blood pressure directly in an artery. If you need extra IVs, everybody's familiar with the normal IV, tiny little catheters that go into an arm usually, or a forearm vein. If you need more medicines, more support, we do what's called a central line, a much fatter IV that goes into a large vein, usually in the neck or chest. But those are some of the more invasive things that we do.
And as you're sitting here explaining this, I guess I'm realizing, is this why probably the ICU rooms are typically larger than a normal room? Because you have to have all this equipment, all the people, all the monitoring.
Yes, this is why we're so thankful for the renovation that we had at the hospital recently, because our ICU is amazing. The brand new ICU is it's so pretty, and the rooms are so large and spacious. Because you're right, you need all that extra space to handle all the equipment and providers and family members and all sorts of stuff.
Okay, so you mentioned the renovation. So let's keep going with that, because we are very proud. We're coming up on almost 2 years. Since opening the new Boyer Bryan West Tower. I can't believe it. But let's talk a little bit, because previously we had 2 different ICUs, right, on 2 different floors. And so now we're able to have everything all on one floor. We have the IMCU unit, which you mentioned a minute ago. So just maybe keep going a bit on why we're so excited. We've also elevated the services we offer too. So it's not just the space, but we're taking care of sicker patients.
We had 2 different ICUs separated by 3 floors in the old hospital. And I think it was just because one wasn't enough and we couldn't put them side by side, so they were on different floors. It was a little bit stressful because when I would be the ICU doctor, I'd be covering patients on multiple floors, and sometimes I needed to be on 2 floors at once, and it was just that was just not the best layout. And so we made a conscious choice to try to put everything on the same level. And so it is one big circle. Yeah. And so one half of that circle is the intensive care unit, and the other half of that circle is the intermediate care unit, or the IMCU. And so everybody who is sick or moderately sick or could get sick are all in the same place. And so for us, that helps a ton so that we can mostly spend our attention and focus in that one location. And as you said earlier, and as I said earlier, just the size of the rooms matters. And so it looks nice and pretty, but it just has everything we need in terms of cables and plugs and monitors and space and all of that to do everything that we need to do for our patients.
Mm-hmm. So let's talk about a typical day, typical shift when you're working in the ICU. What does that look like?
Every provider is going to have a different approach to how they want to manage their day. But the way that I feel best equipped is I sit down in the morning and I look at the list of patients in the ICU. Invariably, there are going to be people that came in overnight and people that I don't know, and so I'm going to just start reading through charts. And then the patients that I do know, I'm going to see what happened overnight, what their vital signs are looking like, what medicines they're on, all the things. Okay. And so I spend, again, depending on how busy it is, an hour to 2 to 3 before I even talk to another human being, just like looking through the medical records and sometimes seeing patients and reviewing their vitals and just getting my brain wrapped around all the patients that I need to take care of that day. Once 8:30 rolls around, that is the official time that we do multidisciplinary rounds in the ICU. And so these are walking rounds where we have a team of healthcare providers walking patient to patient, talking about all the patients in the ICU. And so the team obviously consists of myself, or the intensivist on service, sometimes the hospitalist if they're able to join. The bedside nurse, obviously the most important person taking care of the patient, throughout the day. Yeah. We have a bunch of other specialists that are involved. So a dietitian, sometimes a speech therapist will join. We have an ICU pharmacist who is incredible, who helps us go through every single medication that the patient's on and whether we're on the right dose and whether we need to increase or time to stop the antibiotics or whatever. We rely on them quite a bit. Greg Rumberg, our spiritual counselor, is incredible, and he's there to talk about each and every one of our patients. There is oftentimes a social worker talking about disposition and care needs outside of the ICU, down to the floor and out of the hospital. Okay. And so this big team of people is there to talk about all of our patients, and we'll spend a few minutes, up to 5 or more minutes, talking about each patient and then moving on to the next one. Yeah. So that could take an hour, a little bit more, depending on what's going on. And then depending on what the patients need, this is when things happen. So if they need procedures done, we'll do procedures. We'll get new admissions, and so new patients will roll in throughout the morning or afternoon. And so it really is just, it all depends on what the patients need and what their families need. I'll spend a lot of time talking to families and loved ones about how the patient and how their loved one is doing. We'll talk about goals of care and the next steps and how their progress is looking, or if there's any significant setbacks. And so we just there's a lot of time just to talk and just to kind of get the patients and families acclimated to what's going on. Mm-hmm.
So often in movies or maybe in TV shows, we see the ICU represented. So what do you think Hollywood gets right when it comes to the ICU, and what might they get wrong?
That is a good question, because that is honestly most people's first impression of a hospital, the ER, or the ICU is what they've seen on TV. The honest answer is it depends on the show or movie. Some do better than others, and I'm not sure that I want to pick favorites, but some of them are more dramatized and some are more accurate. I think what they all get right to some extent is some of the medical nuance and detail. But what they totally get wrong is the pacing, the timing, the way that information is rolled out. And so oftentimes you'll watch a show and you're like, oh, that's not a bad representation of that illness. But it all happens within 30 seconds. Right. Patient comes in, this test, that x-ray, that CT, that provider, and it's so quick and so fast. The reality of medicine is it's a lot slower. It's not as dramatic because a patient comes into the ER, gets some vital signs, gets some blood work, gets some scans, and things sort of trickle in real time. Don't get me wrong, the really sick ones declare themselves early and we act more quickly. But, this is not happening in a 30-minute or an hour episode of television. And so, they have to condense days or weeks worth of developments and excitement
Yeah.
into that 30 minutes or an hour. And so I think the pacing and timing is totally wrong.
Right.
And it happens in a day.
Right.
And so that, to me, it's like, that's the biggest dramatic thing. But one common misconception, this is not unique to an ICU, but like the notion of CPR, or like if someone's heart were to stop.
Right.
This is a big point that I have to spend a lot of time actually talking to patients and families about, is what happens when your heart stops? Like, we need to know, do you want to have CPR? Do you want to be resuscitated? And one great disservice that most shows have done to the healthcare profession is make it seem like if your heart stops, we like apply some pads to your chest and zap you with electricity and you come right back. And so I'm not going to say that there's never circumstances where that happens, but the notion that that's the average or common occurrence is so wrong.
Okay.
And so most of the time when you are sick and in an ICU and your body is failing, and then you go into cardiac arrest, generally doing these end-of-life measures, CPR, shocking you, this resuscitation stuff, it generally does not bring back a patient or their loved ones. Yeah. And so that's a common education piece that I have to do, is explain that to them, because they're basing it on television and shows which show a patient popping up right after and chatting and saying some more things. That's just not the reality of how it usually happens.
Yeah. So obviously you're dealing with some heavy circumstances, and sad in many instances. How do you deal with those family conversations, kind of the things you've just alluded to?
It's hard, and to be honest, it's something that I'm getting better at, because it's like all skills in life, like you gotta practice it and do it more. Spending time with people is really the most important. People can tell when they're being rushed and when you're not giving them appropriate attention and you're not addressing their concerns, whatever they might be. And so for me, it's a lot of this. I pull up a chair, like I sit with people, I talk with them, I look them face to face, and it really is a combination of being truthful and being honest, but having compassion. And that's sometimes hard to do. In my experience, most everybody, even in the moment, if they don't act like they want it, most everybody wants the truth.
Yeah.
And sometimes the truth is hard to deliver, and oftentimes it's hard to hear. But it's what people and families need to know what healthcare choices to make. And so I generally lean on compassionate but truth, in terms of my interactions. And so that means saying things that people don't want to hear, talking about the dying process, because sometimes people come to the ICU dying, and there's some things I can reverse, but many things that I can't. And so sometimes a common expression that I'll say is, I can do this to your loved one, but should I do it? And so it's in the moment, there's a lot of emotions, there's a lot of feelings, and I'm not saying it always goes hunky-dory, but like having that kind of real talk with somebody goes a long way to let them know that you care, you want what's best for their loved one, and sometimes survival is not in the cards.
Yeah. And I would assume also sometimes there's some uncertainty too, right?
Yeah.
So you're probably having to make complex decisions about a care path where it might not be black and white. It might not be exactly clear. So how do you deal through that?
Again, as I said earlier, I'm a big fan of candor. And so if I'm uncertain of how this is going to go, I say that. Yeah. I really personally dislike it when somebody gives a false sense of confidence one way or the other. Oh, so-and-so is going to make it through this no problem, or the opposite. There's no way that they're going to make it. I share the uncertainty. I let patients and loved ones know, these are the potential outcomes. And we are all hoping for the best case scenario, but here's some other ones that might happen. And just that truth really resonates with people, I think, because I know, like they do, that the future is uncertain, and so sharing that uncertainty, I think, is my approach.
Yeah. The emotional toll that you, your colleagues, our nursing staff, anybody that's interacting with these patients in the ICU, has got to be tremendous. Got to be difficult to leave it behind at the hospital when you go home at night. So first of all, I just want to say thank you. Thank you for the gift, the services that you give to our patients and their families. But I also want to say, how do you decompress? How do you deal with it, recharge, and come back the next day?
There was a time when I was going through therapy during COVID, because it really felt burdensome then. And I'm not saying it doesn't now, but I was dealing with a lot of death and trauma, and it was a lot. And I feel like I have found my coping mechanisms, and it involves a lot of just doing the things you love and understanding that if you give your best effort and like if you give everything that you got and you really give the emotional best you can, knowing that like there's nothing more to give. And so I've forgiven myself a lot more about, things that didn't go the way I wanted. I cut myself more slack. Yeah. I think I've gotten better to give an emotional connection to the patient, but not give it my all. You have to hold a little bit back and reserve a little bit for your own mental health.
Yeah. Thank you for sharing that. And I absolutely love that you just said that there was a period when you went to therapy, because I think we're starting to talk about that more and more as a society. But to assume that a physician dealing with such, issues that you're dealing with would need to keep all that to himself is crazy. So I'm glad. I'm
happy to share it. And it's not something that was like I hadn't gotten it before, and I did it for a time, and I haven't felt like I needed it since. But in the moment, I can't. I mean, I think it helped me so much to get through it, because there's still a stigma in certain segments of society, which is unfortunate, but it did a lot of good for me, and it helped me be a better everything. Doctor, husband, parent.
That's great. So if somebody was following you around and got to be with you for an hour or maybe even a whole shift in the ICU, what do you think they'd be most surprised about?
I think they'd find that there's an intensity to what we do, that there is a heaviness, as you said earlier, that there's a lot of emotions, but at the same time there's a levity to it. We as a team, I think, are really close, and so rounds sometimes there's laughing that happens. We try to keep the mood as light as we can. And I think that's a good way of balancing the heaviness. And so it's a mixture of both of those two kind of emotional extremes.
Mm-hmm. And speaking of the bond with your team, did I recently hear that you might have made pancakes? You and your colleagues made pancakes for some of the staff?
Yes, it's an annual thing that we do during hospital week, where we do a pancake breakfast that 𝐞𝐚𝐥𝐿, Catherine 𝐸𝐸, the head of the ICU, she coordinates this big, very robust, full breakfast, and we do a minuscule amount of flipping of pancakes, and then we get much more credit than we deserve. But yes, it's a really fun annual thing that she started a few years ago that we really appreciate.
Yeah, I love hearing those stories. I think all of our different departments find different ways to bond and really become a team, and that ICU team up there, we're always hearing great stories about the teamwork coming out of there.
I agree. I think we're a really tight-knit bond, and I think we all kind of rely on each other and help each other get through it.
Yeah, that's good. So I do want to ask, how do you balance the clinical intensity that you're dealing with every day in the ICU with the compassion you talked about is so important for patients and family?
It's a good question, and it's tough, and I'm not sure that I always have it completely figured out, but I consider myself a humanist first and foremost. And so compassion is something that I work at, and I really try to connect with patients and families as quickly as I can, because sometimes it gets carried away. Like the situation happens quick and they need this and they need that. And I don't want to lose sight of the fact that this is a person that I'm interacting with. This is someone's life that we're talking about.
Very intentional. You have to sometimes set aside the knowledge and the skill, the expertise you have.
Yes. We have to essentially be medical translators. We have to take complex medical stuff and put it into a language that a layperson can understand. And again, that's also very intentional. Right. So a lot of what we do is mindful. We just have to be good at what we do. We have to really sit back and think, am I connecting with this person? Are they trusting me? Right. Where's the gap? And just try to make the best of it.
So is there a patient story or maybe a moment that has stuck with you throughout your career?
For sure. I think like a lot of people, I both remember the high highs and the low lows. Okay. And so I definitely remember some outcomes that were not what I wanted, somebody that I expected to do better than they did. But I have a few really positive ones too. One great thing about critical care is I can take an otherwise young and healthy person who goes through a major acute illness and hopefully help them pull through. And so I've got one in particular, a young guy who I still see in my clinic every year, even though I really don't need to. Yeah. Because we just have a bond because of what he went through and the fact that we got him through multiple serious critical illnesses. And so it's super rewarding in that regard. Mm-hmm. I know that we spent a lot of time talking about patients who don't always survive or the hard and heavy encounters, but there's some really fulfilling ones too, where where somebody was on the brink and you helped pull them through.
Yeah. So following up on that, what would you say is the most rewarding part of your job?
It's not just one part of it that I think is rewarding. I love both that I help people survive critical illness and get them to their loved ones and family and get them through it. But I also really love guiding patients and families through the cases where they don't. You know, the dying process is hard and scary, but at the same time, it's part of life. And so I personally get a lot of joy when I do that well, when it really connects and when people really understand that their loved one lived a great life and that letting go is not always the worst outcome.
Yeah. And what a blessing you and your colleagues, the rest of our staff, are to patients and families facing that difficult circumstance. So we're very grateful for all that you do.
Happy to do it.
Yeah. Thank you for being here. I think
this was fun.
This has been great. Yeah.
It's a good conversation. I think community members need to know what we offer here at Williamson Health and kind of hopeful to know what to expect if they or their loved ones end up in that situation.
Yeah. Yeah. Thank you so much.
You're welcome.